All right, so I think we can go ahead and get started now. Good morning again, everyone. Happy New Year, and welcome to our EHE Regional Learning Collaborative session on providing culturally competent and inclusive HIV services for the trans community. My name is Elena Rosenberg-Carlson, and I'm the EHE coordinator here at the UCLA Center for HIV Identification, Prevention, and Treatment Services, or CHIPS. For anyone who may be new to the Learning Collaborative, our purpose is to facilitate knowledge sharing and support collective action across California's 8 EHE Phase 1 counties to help accomplish our shared EHE goals. We also welcome folks from outside these 8 counties to join the sessions and learn together with us. So thank you to everyone for joining this morning. In the chat, you should see an option to send a message to all panelists and attendees. I think a few folks are already using that option. Please do use that option to share your name, your affiliation, and location with everyone on the call today. Next slide, please. So today's session will feature a discussion of various programs, strategies, and approaches for providing trans-inclusive HIV services and ensuring trans folks in our communities receive the support they need to thrive. Unfortunately, we just received word that our amazing third presenter, Victoria, is under the weather, and so she'll be unable to join us this morning. We do wish Victoria well, and we'll proceed with our first 2 fantastic presenters for today's session. As always, please feel free to submit questions at any time during the session using the Q&A function on your Zoom control panel. We'll use the Q&A function to collect and respond to questions throughout the session and also during the live Q&A at the end. We'll also keep the chat function open in case you'd like to share comments or resources with the group at any time. I also want to note that we are recording the session and we'll post the recording and slides on our EHE Regional Response webpage within the next week. So now I'm happy to introduce Deja Cabrera, community health educator and advocate at the San Diego LGBT Community Center. Good morning, Deja.
Good morning, Elena. Thank you so much. Good morning, everyone. Thank you for having me and thanks for being here. Happy Tuesday. Let me let's see, presenting mode. There we go. So as Elena said, my name is Deja Cabrera. My pronouns are she, her, hers, and I am the community health educator and advocate at the San Diego LGBT Community Center. I came to the center in 2018, and my original role was the transgender services coordinator. And I came to this role from Santa Barbara, working at the Santa Barbara Center for about 1.5 years, kind of as their community educator as well. And at that time, I was also beginning my transition and had started in the community, working in clubs, kind of performing and advocating for trans rights and kind of explaining to the audience in the clubs that trans performers are different than drag performers. And that advocacy kind of led me to the center in Santa Barbara to educate folks in schools, GSAs, and ultimately led for me to get an HIV certification for basic training and testing. So I've been a tester since 2017. And in 2019, I switched over to fully be the community health educator and advocate here at the San Diego LGBT Center, where my role is PrEP navigation, PEP navigation, HIV testing, and all things sexual health. I like to call myself the sexual health diva. So anything that the community needs along those lines, I'm kind of that go-to person. And so our Be the Generation program is our sexual health and wellness program. And it started out as a campaign. As you all know, a lot of our state initiatives are getting to zero. And so that's how this started. And so what we realized is that our clients were coming to us more than to get an HIV test. There was additional resources that they might need. And with our clients, it's very client-centered. So every client is different, regardless of their LGBTQ plus or not, regardless of how they have sex, of their orientation. Everyone is different, and everything that we do is very client-centered. So this is what our HIV testing looks like. We do anonymous and confidential testing. We offered the OraQuick and Determine test, early testing, and we do couples testing or testing together. We realize folks in our community are exploring polyamory or open relationships, and so knowing their HIV statuses together could be beneficial. Everything is by appointment only at this current moment because of COVID and all that fun stuff. And starting March 1st, we will be introducing STI testing at the center, which is very exciting. And so what the center is, it's kind of like the middle person. We're not a medical facility. We don't have doctors on staff to prescribe medicine or anything. Folks literally come to get tested. And if things come back reactive or preliminary positive, we immediately connect them to care. And so that is where our service providers come in handy, which I'll talk about in a second. But again, what makes our testing unique is that we're the only site in San Diego that offers anonymous HIV testing, and our testers are community peers. For me, being a brown trans woman, I think it's really cool that other trans women can request me or specifically come to me on the days that that I'm testing to get an HIV test so that we can talk about sexual health, because how we engage in sex or the type of sex that we're having is very different. And sometimes talking to someone who looks like you is going to feel better. So I love all of my clients, and same goes for all of our other testers. Someone who might be bisexual or gay, a woman, person of color, Black, brown, anything like that. Again, our testing is client-centered. So when it comes to trans individuals, if I have a trans client who has a vagina and is having sex with penises, I'm going to ask several questions and see what facility or what organizations they're going to feel comfortable going to. They might feel comfortable going to family health centers, or they might feel comfortable going to Planned Parenthood. It would all depend on the client. So when it comes to our trans clients, it's also just, again, individual based, more specific. I'd say some of our clients have already established care with other physicians. And so reaching out to them and just getting them connected to the system that they're in. It is sex affirming, pleasure affirming, non-judgmental, information and fact focused, educational and affirming rather than isolating and intimidating. I think when trans folks specifically are talking about our sexual health and how we engage in sex, it sometimes feels like we are going to get talked down to or receive some kind of shame or stigma. So it's really nice to be able to just talk to people like they're people and talk about sex like it's no big deal, because we all got here because someone had sex, right? And so we follow up with referrals and additional resources after testing, just to see what additional services they might need. And so when it comes to community partners, here is the list of some folks that we tend to immediately go to when it comes to STI testing or HIV services, treatment, things like that. So these are our go-tos. Here is our testing material. So we try to really be inclusive with what our testing material looks like, especially when we're on social media and advertising, not only to queer folks, but to our youth and to anyone who is just looking for sexual health services. So here are some two examples that we use. Some is, very animated and colorful. The other, what's your tool, is part of our campaign. You can see we have a PrEP pill, we have an ART pill, we have a condom, we have a peach, we have the eggplant emoji. So all the things sexual health, just to make it fun, cute, creative. And, these are emojis that folks are using when they're text messaging or, sending out little things. So we try to keep it fresh and unique to the times. So this is our Be the Generation Instagram and Facebook. Like us on social media. Our original tenets were fight, test, treat, and protect, and we included empower because we realized that when folks come to our services, they're leaving feeling empowered about their own sexual health. We realize that they've realized that they can take control of their own sexual health, whether that be on PrEP, whether it be U equals U, whether it be more condoms, more lube, whatever it may be for them, they're feeling more confident. This is my contact information. If you have any questions, comments, concerns, feel free to send me an email. My mailbox is probably full, but yes, feel free to send me an email. Thank you.
Great. Thank you so much, Deja. I am seeing just a couple of questions already coming in. If you do have questions for Deja, please feel free to submit them directly to the Q&A box, and we'll collect those throughout the session and use them during our panel discussion. So now I'd like to introduce Dr. Antonia Dorsey, Director of Trans Services at Borrego Health. Thanks for joining us, Dr. Dorsey.
Hello all, how are you?
Great, how are you?
I am having a day here. We'll just kind of go with that. It's a good day though. It's a good day. We're here, we're learning, we're having a good time. I'm gonna attempt to share this. I think it is what it is. Yes, this is why I have two different screens going. I'm weird. Is it coming up yet? Is it showing? I can't tell.
Yep, I can see your slides, and I think if you just want to start the slideshow, you should be all good.
All right. I can't see what I'm doing here. Okay, I'll go this way. Nope, that didn't work. Okay. There we go. All righty. Sorry about that all. I'm having technical difficulties because I am both not technical and very difficult. So we're going to talk real quick about trans healthcare and HIV for this particular thing here real quick. It's going to be fun and exciting, and we're going to have so much joy and happiness. So everybody knows who I am. I am Dr. Sunny Dorsey. I am the Director of Trans Services for Borrego Health and FQHC. We have patients in San Diego, Riverside, and San Bernardino counties. We also have patients in other counties, but those are the three that we serve officially. I am just your typical trans woman. That's what I like to point out. I am mixed race. I'm bi. I'm a trans woman, as I pointed out. There's all kinds of stuff. I use she and her for your comfort. My actual pronouns are much more complicated. For those who are curious and do not know, my actual pronouns are Empress, Your Royal Majesty, and thank you, may I have another. I gave you the quick Borrego info ahead of time. So my email address is adorsey@borregohealth.org. I serve on the Inland Empire HIV Planning Council, ideally to represent the trans community there, but I also, because of the nature of our structures, I also represent Borrego Health, rather obviously there. I am the one of the primary administrators for the International Transgender Health Group on Facebook, which is significantly larger than the entire membership of WPATH. And for those of you who don't know what WPATH is the World Professional Association for Transgender Health. You can find that website at wpath.org. They release the standards of care and every now and then. And currently, they just closed draft comments on standards of care version 8, which will be released this year, probably in the second quarter for what's going on from there. So I want to talk about some central points that are kind of key here. How to build trust, how to avoid mistakes, how to get buy-in, how to change and make history. Those are the basic things we're all here to talk about, really, when it comes down to it. I'm going to kind of take a larger overview, and then when we're doing questions and answers, we can get into the detail stuff on how to do stuff on a basic structure here. So I'm going to also tell you that the 4 things I want you to think about are demographic data collection. I know you're all going, oh my gosh, demographics, that's just so much fun. And data, wow, we just really like that. We do a lot of data collecting already within HIV work, but I'm going to just tell you straight up, we don't do it properly when it comes to trans people. Descriptive over prescriptive. And this was something that was actually highlighted recently and is really brought out more strongly in the Standards of Care version 8. Nobody really seems to be able to agree, except for trans people, on who's a trans person. And so that means that when people are doing studies to try and determine how many trans people there are, the information can, and the number that results is wildly different from other studies. I'm also going to talk about basic bias and habit challenges that we have. Those are the primary things that you're all running into already. These are the issues that you have and the reason why we have those 4 little questions there. And then I'm going to talk to you about nothing about us without us, which I'm sure most of you have heard at some point or other. And yet this is something that you cannot avoid within the trans community. As a sociologist, I'm going to just point out that there's a network structure within the trans community, and one we've all heard about the whole 7 degrees of this. You know, we're all 6 degrees or 7 degrees related from somebody else. Trans people are 3 to 4 degrees away from somebody else. We all know somebody who's going to do it, and if you're active within trans community efforts or even the science, you're likely to have a contact with that person. So let's say you see an article about something relating to trans people in a publication and you want to get a copy of that article, you can usually find a trans person who's going to know either another trans person or another researcher, and they're going to know the person that you're talking about, and you can usually get a copy of the article. It can be really fun at times. So the first challenge is to identify the population. The first major challenge we have is that the history of HIV medicine is filled with a lot of history of trans people being involved, but almost no data on them. For the vast majority of the last 40 years, trans people were classified as men having sex with men, which explicitly calls them men. It doesn't matter if you don't say men having sex with men. If you just say MSM, it's still the same thing. Doesn't make a change or a difference there. And that's really important key, because by doing that, you actually erase not only the trans population, but you also erase the potential of the trans population that you're ignoring. Note that trans masculine and trans men, which are 2 distinct things, as well as non-binary folks, were excluded from that, as I just mentioned. So we didn't know that there were trans men out there who were gay, who were engaged in sex with other men and not being approached or talked to about HIV or PrEP or anything else. They changed that about 3 years ago, about 3 years ago, when a study that the CDC backed was finally released relating to PrEP and the impact on hormones, because that was one of the larger things that was challenging us. Electronic record systems, your EMRs, your EHRs, all your stuff there, typically do not effectively capture the demographics of trans people. This is a really big challenge, in part because the way that trans people are classified and grouped is ultimately determined by the trans community, and is a general rule, for the most part, the cisgender community, those people who are not trans and not intersex and just generally, kind of fitting in outside of it. They don't seem to understand that point. And so they keep trying to make up their own rules. But as I've noted before, how we do that particular approach in collecting and identifying trans people really matters, because if you do it wrong, you have too small a population. And if you do it right, then you have a much larger population than you may realize. All of this combines with a deep ambivalence and general animosity towards trans people as being difficult, too much, and forcing change. My particular job is to be difficult, to be too much, and I'm sure most of you have already noticed that I'm already pretty much, and also to force change. So, I mean, I can't really fault people for seeing that. However, I will point out that that's my job. And the nice thing is I'm getting paid to do something that I would already be doing just by simply existing. So what is the first solution? The first solution, of course, is cultural humility. I'm going to be blunt. I'm still adjusting to this idea of calling it cultural humility. I think of it in terms of competence. Anybody who has as many letters after her name as I do tends to think in terms of competence. And it's an important thing. I don't take incompetence as being bad necessarily. I take it as an opportunity to improve. But a lot of people think that if you call me incompetent, you're threatening my career, my livelihood, my everything else. So switching to humility makes us understand that we have to be humble when we approach other people. And I don't have a problem with that. I have to be humble just trying to approach cisgender people outside of the transgender experience, because if I'm not, then they look at me as being too difficult and challenging. And you guys get the point there. There are a lot of approaches to this kind of stuff. As a social psychologist, I tend to prefer a behavioral approach that identifies not merely overt discrimination, but also the subtle stuff as well. 4 examples that I like to use, and you'll hear me every now and then if you get to see me a lot, I talk about the 4 A's, and that's because I classify these things into 4 groupings. And I find that when you approach the idea of creating policy and other structures to, if you use these 4 A's, you can find out ways where you're missing stuff. Ambivalence, or not really wanting to get involved, or, you know, it's outside of my thing, or all of that other stuff. It's not wanting to have to do the work. And when you're doing a job and you're trying to reach everybody, you have to do the work that's necessary to reach everybody. Anxiety, which does include anticipatory ideation, is another. For any of you who've ever had kids and you are kind of wondering what I mean by anticipatory ideation, it's that phone call in the middle of the night when they're out on a date, and you just know that phone call is going to be the world's worst thing. Everything, you imagine people lying dead in a ditch in a car accident or something, that before the phone call, that's anticipatory ideation. It's what's going to happen if, or when, or how, just because something changes. You don't have any real basis for it, but that's what anticipatory ideation is. It's a really good example of how anxiety impacts us, because we oftentimes think of anxiety as a mental illness issue or something of that effect, and it's not. It's a way of thinking, and it changes your perception of the world. Aversion, which is, you know, trying to push people away or pull them towards you, is another example of that. And I apologize for my poor typing there where it says deal with. Not always going to be on the best thing there. The rarest form, surprisingly enough, people think that this is the most common form. It's the structure that people use most frequently, including us trans people, is animus. And that's the intense dislike of trans people and things about trans people. That's the most overt stuff. We see that right now going on with activities where just being able to provide medical care to people is being turned into an illegal act. We see it with recent efforts to deny trans people full participation in society and in our culture by saying, oh, you can't compete in sports. And when I say you can't compete in sports, what they like to challenge, make that seem like is, well, I'm going to say that, you know, a trans woman is not going to be having an unfair aspect against cisgender women. And then my immediate thought is, well, what about the trans guys who now you're saying have to wrestle with girls? And so they're saying that we can't participate, and there's not enough of us in order to be able to create an entirely new category where, you know, we have trans football teams or trans soccer teams or trans swimming teams or trans tennis teams. We can't do that. And so we have to find a way to allow people to do all of that. So next. Demographics are the next thing, and this is the second solution, and that's improved data collection. I'm going to point you out to the interesting little photo for restrooms. Yes, the 2 genders. We see all kinds of strange restroom signs out there, and some of them are very creative. And those within the trans community, we like to laugh about it because, yes, the two genders of whatever these are. There's fish and there's bowls. You know, men and women tends to work as well, except that there's not just 2. There's a lot more than 2. So demographics should always include a 2-step process. That 2-step process should be sex and gender. Sex would be male, female, intersex. And since you have to record on the basis of birth certificates, at the very minimum, an X or an N should always be included, because there are people who have birth certificates that state X or N. And if you record them as M or F, you're already committing fraud when you do your reporting. That's just the basic structure there. Gender is where it gets a little more confusing to people. We tend to equate man and male and women and female, and that's kind of thinking is one of those more subtle structures that we need to change. Oh my gosh, Tony's asking for change. She does that way too often, that we need to change in order to make sure that we are able to provide those services. So man and woman, non-binary, some ways of saying non-binary are NB, which is how we actually talk about a lot of those folks, or N and B together, meaning non-binary. Gender fluid, gender queer, demi-genders. There's demi-boys and demi-girls, agenders, and there's even more, and those can vary from locale to locale. And the reason I always say locale to locale is because we have 3 counties as an example, and there's a larger population of bigender people in San Diego County that we deal with than there is in Riverside or San Bernardino County. And you note that I don't include that as one of them. There are a lot of different potential gender identities that you can see, and therefore there's a lot of different potential genders. That means that our systems that don't even record those alone are already short and already failing to be able to do it. And if we don't have good data, we can't identify the best ways to reach those populations, and we can't identify how to reach those populations because we don't know that they exist within the data. The bounds for trans demographics should be descriptive and inclusive, and based on 2 key principles, affirmation and self-identification. The reason that I'm going to tell you you want to include those 2 core principles there is, 1, every time cisgender people have created an effort to do this, they've screwed something up. And it's not because they're cisgender people, it's because they don't understand the trans population. So that creates a big problem. And it's not merely an issue of, well, we want to help this particular grouping of people. All of the things that people use to define a trans person are cisgender constructs. There's ideas that are built into our society and our systems. And trans people don't exist within those societies and systems. And so we have to try and bolt something on, and it doesn't create a solid framework that we can use in order to do effective data analysis. I really want to point this out. A lot of the typical studies use a prescriptive and exclusive basis for deciding who is trans when you're doing the count. The most famous example of this, for example, is the numbers put out by Williams Institute. We are all using them. I use those numbers constantly as a base population model. Those population numbers, the most recent ones are between 1.2 and 1.8% of the population. The interesting thing is that those numbers do not include any form of non-binary person. It's strictly trans women and trans men, and it doesn't even include an effective enough count among the population that is under the age of 25. So it has significant problems in design and structure. And one of the things we found is that the numbers, depending on how you define trans people, can vary from 0.1% to up as high as 8%, actually more than 8% of the total population, all depending on how you describe and affirm trans people. And that actually is something that there's an entire chapter on in the upcoming Standards of Care version 8, which I thought was absolutely wonderful to see, because it points out the foolishness of trying to count a population that you can't agree on who is included unless you're a member of that population. Solution 3 is to include trans and gender diverse folks. I know all of you have heard this more and more and more, and you're like, oh my gosh, and this is the nothing with us without us, nothing about us without us. So the scientific and medical study of trans people and the modern understanding, the way that we think of trans people today in our society right now, has over 150 years of history behind it. In the US, for about 100 of those years, the baseline has been to treat trans people as crazy or mentally ill, or having some sort of problem that is either the fault of bad parents or that they are just broken people. That's the norm. That's the standard. That's the basic. Ultimately, the DSM-5 still does that. The ICD-10 continues to do that. But the ICD-11, which was released last year, and will probably take a little bit of time for the United States to catch up, given the ICD-10 was released in 1990, and it took us 21 years to get around to putting it in place. that's no longer the case. Actually, under the ICD-11, trans people the issues around them are not listed in either medical or in behavioral health. They're listed in their own category, much like pregnancy, as something that needs help. This particular category is sexual health and wellness, which brings us back to my co-presenter here and the amazing work that she's doing down there for the LGBTQ Center. Trans people resent this. You'd think we wouldn't if there wasn't a problem with it, but we do, and it kind of gets in the way sometimes where we become used to it. We do not become inured to the way that we're treated. And so even though we have to engage with medical care at large, just be able to move through a process and be able to deal with things, we don't trust cisgender people. We don't trust you. You already know this. You know that this is part of the reason why it's so hard, but now you know why. Generally speaking, most of us have had at least one negative experience when entering into any kind of care system, regardless of the intent or anything else. I'm just going to give an additional example. Trans people are one of the populations that suffer from the highest degree of homelessness in the United States. Trans youth have been accounted for, particularly here in California, being at least half of all of the people who are homeless at some point as minors. And it's important to keep in mind that as we mention this, how many shelters actually provide spaces for trans people that are affirming and that are inclusive of those trans people in all of their gender identities. I'm just going to tell you that it's surprisingly very, very few, despite having rules in place and everything else you would think. If I were to be homeless tomorrow, I would probably have to be housed within a space for other men, regardless of anything else, because people are just going to be like, hey, you're a guy. We understand what you want to do. In some cases, for very, very famous and well-known organizations that provide these services, they'll tell you on their website and everything else that yes, they're 100% affirming and accepting of all of this, and trans people can stay however they want. But then when you actually go into those locations, they inform you that you have to dress and act appropriate to the assigned gender at birth. Starting in 2007, US trans-based groups began and continue to engage with a basic standard: nothing about us without us. If you want to reach trans people, you must hire trans and gender diverse people into your organizations in contact roles and in leadership roles. And I want to stress that in the leadership role is also very important, as I'm in the leadership role. I think that it's really wonderful to do that. But the real reason is because if you just hire them in contact roles, they're not going to be able to have as great an impact on policy and structure as they need to have. And therefore, you're going to continue to fall apart. A lot of people want to place additional restrictions on trans people in order to make those roles. As an example, you must have a master's degree, or you must have a bachelor's degree, or you must have a doctorate, or whatever else. And I'm going to tell you, stop doing that. And the reason why I'm going to tell you to stop doing that is that trans people have a harder time getting that education. They have a harder time getting through all of that stuff. They cannot get the support and the systems that they need. And therefore, by making those additional requirements in part of the job, you're actually creating a limitation on yourself so that you can't fill that position effectively. Because although there's a lot of us out there and a lot of us are doing amazing work, we aren't as mobile as you might realize, even if we have a lot of education and we have our own priorities. And if you want to bring us on board, you have to meet some of those priorities. All care for trans health must be done from a trauma-informed perspective. When you start transition as a trans person, pretty much regardless of when you do it, it is what we call a crisis point in psychology. And that means that you're extraordinarily susceptible to all kinds of outside influences. You're more readily able to develop maladjustment behaviors and coping mechanisms. And you're having to deal with a whole different way of interacting with and engaging with the world around you. And it can be really, really challenging. At the same time, you're having to inform the world that they have to do something different. An example is, most of us who've worked with trans people for a while, or who are trying to, we recognize the importance of sharing our pronouns. And I point out at the beginning that I use she, her for your comfort. those aren't my pronouns. I'm doing it to make it easier on you. My pronouns are Empress and Your Royal Majesty, and thank you, may I have another? And those are officially my pronouns. I put them out on all kinds of business stuff. I'm doing it here, even in a major thing. And the reason why I have those pronouns is because if somebody walks into your clinic or your community center or whatever and says that their pronouns are meow and mew and mim, you best use those because those are their pronouns. It's not a preference. That's what you're supposed to use. But the simple fact that people have to think about that and they have to ask and they have to do things, that's a behavioral change that is extraordinarily difficult to make happen because everything else around us, when we're not dealing with trans people, and that's most of the world, about 92% of the world, assuming the 8% is accurate, you're dealing with a population that doesn't have to do that, where everything's already taken into account. And so it creates a sense of bias and recognition within us that this is what we have, this is the norm, and now we have to make an extra effort outside of the norm to deal with these weird people that we call trans people. So why am I doing all of this and not saying, well, this is how you do it, these are the steps and everything else? Trans people deal with a significantly higher levels of anxiety and depression. You already know that. Everybody ascribes to that the suicidal ideation aspect. But I'm just going to tell you, it's also why we're not having any success in getting through to them. I have a story that I tell when I'm doing training about a trans woman. I used to run a housing and development program in Arizona, largest trans program in the state for a while. And one night I'm sitting there and I'm just kind of hanging out and I get a phone call and it's about 2 o'clock in the morning. And I have my own anticipatory ideation concept. Turns out that it was pretty close. I had a former client of my program who got into a spat with a roommate and ended up with a knife in their lower belly. They went to the hospital with the knife still sticking out of their lower belly. And they got into the emergency room, and of course, the emergency room technicians rush them into the ER structure and everything else. We're going to get that knife out of you. We're going to get you stitched up. We got to do some, imaging and everything else. And they say, okay, so sir, what's your, what name should we use for you and everything else? And she got up and she walked out because they were misgendering her and they were using the wrong name. She would rather drive around for 2 more hours trying to remember and find out what my phone number was in order to call me because she had heard that 20 years before I had served in the United States Army and that I had some medical training. That's how important it is. I'm not qualified to do that. That medical training was first aid in the military. So I say that because I want people to understand that this is how important it is. If you want somebody to be in care, if you want to be able to take care of them, you have to treat them with respect and with dignity. And if you fail to use the proper name and the proper pronouns, you are not doing so. So names are not a preference. Pronouns are not a preference. They are the interpersonal interactions that we have. Being able to identify someone's gender identity properly is really crucial. I'm trans. I've been doing this for 20 some odd years. And I'm just going to tell you that, you know what? I still have problems with non-binary people. I have 2 non-binary individuals on my staff, and they're really, really helping me to get through that. I rely on them and they help me because they know that I'm going to help them. That's really what it is. We're taking care of each other. So all of this really comes down to that idea of language matters. And I'm going to drive home, going back to that anxiety and depression thing and point out that, every time you encounter a gendered experience as a trans person, and that's between 4,000 and 8,000 times a day, it's like having a mosquito bite hit you. It can be TV shows, it can be magazine ads, it can be somebody using the wrong pronoun with you, it can be whatever. All of these times that it just drives home, I am not as pretty as I would like to be. I just turned 57 years old and I don't look like all the models on TV. All of those things that we think of in terms of some stuff still apply to trans people, and we forget that as a whole. So we tend to think of those as being inconsequential as individual stuff. But it's important, especially when we're reaching into the trans community, to remember that these things have a cumulative effect, like a mosquito bite. The way when I'm training, I like to do things, I like to ask people, how many mosquito bites are going to make you stop going outside? If any of you have ever lived in mosquito-based country, usually it's about 5. but every single one of us has a different level, a different tolerance for the number of mosquito bites that are going to make us stop going outside. But what if you can't go outside? What if you can't go inside? What if you can't escape those mosquito bites? What's your tolerance level then? What is it that you're going to do ultimately to stop having to deal with those? And which one of those mosquito bites is going to be the one that finally cracks the back, the camel, you know, the last little straw on it, and you decide you're going to end your life because you just can't take any more mosquito bites? Nobody has a clue. You cannot ask somebody what it could be, how it could be, when it could be. And that's a really key element that people have to understand is going to happen. So care for trans positive folks is actually easy. All measures are done the same way you do everything else. The difference is the way that we engage with and treat trans people. And that's really kind of the key here. It's not that there's something special to do with the medicine. We know that there's no difference in hormone treatment and PrEP or PEP, or even with most of the HIV treatment regimens that we use. That's not going to have an impact. We can't say it with absolute certainty because nobody's bothered to test it, because trans people aren't enough of us to justify the testing. Again, these are all underlying biases that we have when we approach the kind of work that we're doing. Trans people do not exist to meet your expectations of how men or women are meant to be. They exist to create new expectations for you. It's not our part to be what you want us to be or behave in a manner that you think is appropriate or proper. It's your job to understand that we're expanding those concepts and ideas of what is man, what is woman, what is non-binary, what is androgynous, all of those different things. We put an inordinate amount of effort into negotiating this world, to moving through it, to passing through it. We go through a ton of surgeries just to be able to deal with things as we go. Trans and gender diverse people are too often seen as an additional burden, as a difficulty, as a problem. And I'm just going to ask all of you to think about that for a second. How many of you have thought to yourself at some point, oh my gosh, we have to spend more money, we have to bring in more people, we have to do this extra thing in order to treat trans people, when really all you have to do is think about how to treat them with the same level of courtesy, compassion, human dignity, and respect that you treat the rest of your patients. And if you aren't treating any of your patients with any of those things, well, why are you in the business in the first place? So now I think we're going to move on to the questions and answers part, and they're my favorite. And do not hesitate to ask questions and answers because I love them.
Well, thank you, thank you, thank you. Thank you so much, Dr. Dorsey, for that great presentation. As Dr. Dorsey mentioned, we are going to now move into our panel discussion. So we're going to start with a few questions that were commonly shared as part of the registration process. So these questions were things that came up across many registrants. And then we'll move into some open Q&A. So feel free to continue submitting questions into the Q&A box as we're chatting. We already have some great ones in there, and we'll be sure to get to those later in our panel discussion. So I want to start with this question that was submitted pretty frequently during registration. Several participants asked, how can HIV service providers build ongoing trust and better communication with members of the trans community in their daily work, and especially service providers who are not trans themselves? So I think both of you touched on, different aspects of this question in your great presentations. But maybe Deja, do you want to kind of get started with any other insights you'd like to share on that question?
I have a ton of wonderful doctors and physicians that I'm able to work with at UCSD, SDSU. And so for me, I think when clients are coming to me, I like to have like a warm handoff. For me, it's about my experience. And so, for example, I have Kaiser Insurance. And so when a trans client is coming to me with Kaiser, I'm able to help navigate exactly who they need to go to because I've done it myself. When it comes to other organizations, I know people. So because they know me, there's trust building. So yeah, I think, a warm handoff, even if I need to go to the appointments myself with the client and be that advocate, and have that kind of conversation of just, we're a team. We're going to work together to, give you the best care that you deserve.
Thank you so much. Dr. Dorsey, did you want to chime in on that question?
So I'm going to tell you that the easiest way is to engage with the trans population as a whole. As I'd mentioned before, and as Deja actually just pointed out in terms of experience, trans people are going to tend to trust other trans people more likely. I'm not going to tell you that it's universal. There are trans people that we don't like. And the concept of a drama queen seems to be something that actually came out of the trans community, because we're all queens and we love our drama, and it just kind of runs across. But if you don't know that, that's something you can go ahead and learn, and we engage with that, and it's something that's really key. So first off, make sure that you have trans people there to do it. If you don't have a trans person on staff, most of them, if they have time, will be willing to volunteer. But really what you need to be doing is recognizing that based on the larger social systems that we're dealing with, hire them. Because you know what? The more of us that are working, the more you're all going to have an easier time of doing this. Because just having to deal with this on a daily basis as coworkers makes a change. The next thing is, if you know trans people, if you're engaged with them, you're going to find the language that you need. And that's really the key part, is being able to say, you know what, I need to know what you are when you're dealing with a demigirl, or what is the difference between androgyny and non-binary? I don't understand this. Where's that structure? If you know trans people, you can find that out, and then you'll find out that it depends on each individual androgynous person or non-binary person, and you realize that, you know what, we're people. And just like everybody else, we have lots of things in common, and then we have a lot of important things that are different. And those differences are what define us as individuals. Whereas what we're trying to deal with is the larger, more common stuff. But we still have to deal with each other on a basis and level of dignity. So that's why we push the idea of hire trans people. If you can't hire trans people, then what you need to do is you need to go out and sit with them. You need to talk with them. You need to learn from them, and you need to keep your mouth shut while you're doing it. Find trans people who you can ask questions of, regardless of knowing whether or not you get them phrased right. That's not every trans person. You can't just walk up to any trans person you want on the street and ask them a question. You can't just ask any client that you might have. You have to find the people who have taken it upon themselves, and in addition, have the experience and the larger base knowledge to do it. I'm going to tell you that part of the reason why Deja and I put out our email addresses is because you can probably reach out to Deja as well as me and say, hey, how do I ask my patient how they have sex? Because that's a question that you should be asking, especially when you're dealing with HIV, because you know what? There's a lot of different ways to have sex, and trans people get more creative than most people realize when you're doing it. How do you ask a trans person about their body part inventory? And that's something that you're probably all going, what is a body part inventory? I'm going to tell you that a body part inventory is, these are the parts you have. This is not something you should just be doing with a trans person. This is something you should be doing with every patient, because, some cisgender women have had a hysterectomy. Some cisgender women have had full mastectomies and new implants put in. You need to know what the body parts you're dealing with are, because if you don't, you can't do the appropriate medical interventions. You can't make sure that they're having the appropriate structures, and you're not going to ask the right questions when they go in for the sexual wellness questionnaires and exams and everything else. And you have to be able to do that. That's a really key thing. But if you don't know trans people, you're not going to figure out how to do it. Now, you can reach out to me and Deja. Both of us do this all the time. This is kind of our lives. I whine all the time about how when I started out, I didn't want to be a professional trans person. That was, 20 years ago. I mean, it's so bad that I spend a lot more time telling people, yeah, I'm a social psychologist and I with a focus on sociology instead of psychology. And I'll go into this whole long thing about how many different degrees I have and all the other stuff that I went and learned because I didn't want to have to deal with the world as a trans person. And yet I'm still a professional trans person. This is what I do all day long. I've done it at the UN level, at the federal level, at the state levels. This is all I do. So I don't have a problem answering those questions. Now, does that mean that I'm the only person that can do this? No. Deja can do an amazing job. There are people in your communities that are local to you that can do amazing jobs. And all you have to do is reach out to find out who they are. And that's really key. If you're dealing with a local community, you have to deal with that local community. Some of you may have known about Cecilia Chung, who's been doing this work for years. Cece is a really close friend and also one of the people that I think is a hero. And yet, how many of you have ever heard of the work being done with the trans positive HIV cohort that she happens to be a key contact for? We all know about our HIV research cohorts. Well, there's one that's specifically for trans that's across the United States. And if you don't know trans people, you're not going to know how to access it and you're not going to know how to get into it. And that's all driving why I keep saying you must have trans people available. You must know them. You must engage with them. That's absolutely essential.
Thank you so much. And I just want to also thank you both so much for offering to be a resource, for our learning collaborative community and also in your own communities. I mean, clearly both of you are such amazing resources in this work and just wanted to really appreciate that. And, we're hearing that also in the chat. Thank you so much for offering to be a resource even after the session. I wanted to actually kind of interject with a question that came in during today's session that piggybacks off of something you said, Dr. Dorsey. So in the event that you as a service provider accidentally misgender a client or maybe use inappropriate or inaccurate terminology in your client interaction, how would you recommend approaching the correction?
Deja, you want to go first?
Yeah, I think, that's a great question. I think forms, and especially forms, all have, things on them, right? And so luckily for us, we have a great team at the county that we work with and, just always talking about language and what feels good. And so on our forms, when it talks about identities and things like that, we do have a current gender identity and a sex assigned at birth question. And so when I'm asking those questions, I disclose that this is a question we ask everyone, and it sometimes can be uncomfortable, and you have the option to not answer. And so I always disclose that with my clients. If I do make a mistake, I immediately correct myself, apologize, and then I move on and then, continue the conversation. But like what Dr. Dorsey said about, how we engage in sex and, instead of saying, who are you having sex with? I always ask, how do you have sex? What kind of sex are you engaging in? So there's always different ways to ask questions that feel good.
And I'm just going to say that, yeah, the approach is, and as I noted with my own team, I mean, these are people I work with every day. You'd think I'd get it down, but it's difficult. And I get that. It's challenging because it means we have to monitor ourselves. But what I do is I'll be like talking about one of my navigators and I'll go she, and then I'll change it to they in the next sentence and everything else. And if they have an issue or a question with it, I will go, you know what, I apologize. I'm sorry. I'm continuing to work on that. And to give you an idea of just how broad this is, my own child came out as non-binary, and I still call him my son on occasion, and he's okay with that. He and I had that conversation. But if somebody else calls him my son, they're like, I'm going to be like, what? And they're like, oh, I apologize. Let's go. And that's it. That really is it. Don't make it the next end of the world thing. Yes, it's true. It may be the final straw, but you know what? Part of the reason it becomes the final straw is somebody is like, oh my God. And we spend so much time trying to negotiate the world that we now feel bad because you feel bad, because suddenly that's our fault. We take that on. And when we don't, well, those are the patients that we all love and enjoy. I mean, that's like dealing with me, and I'm sorry if any of you have to do that. I'm heading down to UCSD and they're all excited because they're terrified of me. And I'm like, you guys have Bics down there. How can you be afraid of me, of all people? So yeah, it's don't make a big deal of it. Apologize and then don't do it again. Just like you would with something else. You know, somebody just got married, they just changed their last name. You look on the chart and then you look at them and you use the name before they got married, you know, their maiden name or whatever else. Oh, oops, sorry. Okay, Mrs. Billings or whatever. There you go.
Thank you. So another question that came up frequently during registration was, what are some key considerations for developing an HIV prevention campaign focused on reaching the trans community? So we have many folks part of the Learning Collaborative who are working on these sorts of, you know, kind of broad HIV prevention campaigns, and are wondering, are there any particular considerations or recommendations you might have for doing that in a way that will effectively reach the trans community?
Yeah, I would say include trans men, non-binary folks, Black and brown people. And I would also stay away from like the sex work narrative, the trans women sex work narrative. I think that is just so, you know, we can move past that. It's 2022, and, you know, let's include folks who have vaginas, folks who, who are intersex, folks who are diverse, folks who are, you know, handicapped or, disabled, or, you know, whatever language that is, you know, so include all of those people and get away from the sex work vibe. Yeah, that's my advice.
I will back that 100%. I'm going to tell you, anybody who's ever had to survive in this country as a trans woman has probably considered sex work at some point. And that means everybody. That includes the billionaires that we have in this country. That includes people like the directors and creators of The Matrix. I mean, the sex work is not something that you can use as a basis. Sex work is really kind of how you live. And I've worked with a lot of sex workers, and oddly enough, they were the least likely, in my experience, in my populations, to do this. So no, don't do the sex work narrative. But the thing I will tell you is the trans people that we're missing are the ones that fall through all of the gaps. They're the ones who are typically the poorest. They're the ones who have the lowest information access thing, you know, particularly today. And right now, for example, a lot of us are sitting here on a Zoom webinar, and just the ability to sit on this Zoom webinar is something that's outside the reach of a lot of our patients. You know, we serve the trans patients in San Bernardino County. I've got some trans patients up there who have not been able to see a provider other than by a phone call, not video, which is what we would all prefer, especially me, because I like to be able to check on my patients, but a phone call. That is the way they can do it, because for the last 2 years, they haven't been anything else, and they can't afford any more important access. And that's despite the fact that a lot of those trans people have, you know, are amazing. We spent the next 4 years of our income on our phone. It's just that we can't afford, you know, to do more than, you know, 6 days at a time and pay, you know, for out of 30 days. So when it comes to things like that, that's who we need to be able to reach. And that means boots on the ground. That means people who know the community. That means being able to provide locations for people to meet, whether they're virtual locations, even if it's just a phone call where everybody can talk together. You know, even within the trans community, we fail this all the time, because a lot of us who have access to things like Facebook, for example, which we take for granted as being able to link all of us together, no, it doesn't. And not just on the basis of, well, I'm better than that, I don't need to be on Facebook. I'm talking, I can't get an internet connection that's not dial-up type level stuff. Okay, and I look at my numbers and that's what I see. But another element here is when you're planning your structures, if you don't have a way to identify the trans patients in your system, you're not going to be able to say, this is who we have to go after, and this is why. If you can't do the data breakdown, you can't do it. Again, I know that it's crazy because it's the scientist thing in me, but you have to have the data. As our wonderful hosts know, it's a pet peeve of mine that the number of trans people that are reported to my teams to the HIV Planning Council from the state are lower than the numbers of HIV trans people that I have in my own system, in my own company. So there's breakdowns in data, there's breakdowns of stuff, and part of it is we can't do the reporting up, and part of it is the reporting that comes out of the systems isn't there because it doesn't contain the demographic structures that we need it to have. So if we don't know who the trans people are that have HIV, and we literally don't, when we're creating a program, if we don't set that entire program up to specifically focus on making sure we identify and include and report trans people, we're not going to be able to do it. And if we're going to include and report trans people, we have to do it as a whole. One of the questions that I noticed that popped up was, what is an X or in the sex field? Certain birth certificates have a non-binary designation, in or X. It depends on the individual state and or country that they're coming from. And this is part of the demographic data. You know, I look at my own EHR system that we have in my own company, and it says, you know, you have M, F, no answer. There's a section missing there that legally we need to include, and that would be the designation on the assigned sex at birth structure. That would be that designation that we need to include, because if we just force them into don't answer when they want to provide an answer because they're X or in, that's there. And while a lot of people may think that's new, and it is new, it's not just adults that are going to be coming in to do it and to offer it. It's also going to be parents of young children. The other thing I'm going to tell you is basically the rule that we should all be looking at is, if you have sex, you need to be included in a prevention campaign. That's the rule. It's not an age thing. It's if you have sex. If we try to cut it off and say the things, all we're doing is letting it continue on, and we need to make sure that we reach everybody. And that means we need to be able to support everybody regardless of age. I live in an old people colony. I mean, an age restricted community. The houses were cheap. And I'm just going to say that there's an awful lot of sex going on here, and there's very little sexual health and wellness structures going on. And I'm like the youngest person in the entire area. So I have a lot of work to do with my neighbors, and just generally walking out to the mailbox. I still do that work. They do think I'm weird. I'm not going to pretend otherwise, but I am. So there we go. Next.
Thank you so much. So this is the last question I'll ask that came in from registration, and then we'll go into our many, many great questions that have come in throughout today's session. So this question from registration is from some of our public health partners. And the question is, how can state and local public health agencies best support organizations on the ground working to serve the trans community?
Money.
I was just going to say, send more coins.
No, seriously, it's you know, do your due diligence, make sure that, you know, you have a reporting mechanism in hand, make sure that that reporting mechanism is followed, make sure that there's consequences of failure and all that. Do that part already. But you know what? The trans community will organize its butt off for you and do all of the hard work, but that requires money. I'm serious. Tomorrow I could create a program for any function you want in this entire system. I could do it. It would take me about 6 hours. I would call Deja, we would talk for about 2, and then we'd write something out and we'd go, okay, that looks good and it is done, but there'd be no money for it. And that is the single most important thing, is because we would reach out to the trans people to do it. And we would say, hey, these are the 4 best people we have to reach this area. We want to reach El Cajon, we want to reach Oceanside, we want to reach Escondido, we want to reach you know, right down there at the base at the gates. Okay, we know these 4 people to do it. I really wish Victoria were here.
Right. And we can do it. And like the thing is that I think the trans people are so resourceful, and we know how to rally together and fundraise and, raise a lot of money. It's going to take us probably a little bit longer than what we want to, but if the state is sending us some coins, writing us a check, here you go, mamas, thank you. And, we'll get to work. So yeah,
And
write us a check.
I'm sorry. It seems like it's the most trite answer, but this is a community that is so poor. I love to use my cudgel when I'm talking to politicos of, hey, I lived for a decade on $400 a month. I have 3 advanced degrees and 5 bachelors, and I couldn't find work for 10 years. Because I'm a trans person. That's a reality that we all have to deal with. One of the nice things is that people forget that California is the promised land. I am not a California native. I'm an Arizonan. So, I grew up hearing how horrible California was. But it's the promised land, and all of us here in the Inland Empire area, we're built right along I-10. San Diego is right along I-8. Those are major arteries into the state. And ultimately, they all flow up to San Francisco. And when trans people say, hey, should I go to San Francisco? I say, no, you go wherever you happen to be. But if you're going to come to California, and a lot of us do, go to where there's services. And that's the problem. If you have an area, make sure there's services for trans people. And that means give them money. It doesn't mean give them individual money that they can run off and have their surgeries. That's not what I'm talking about. I'm saying help them form organizations and give those organizations responsibilities to go with that funding and make that happen. But that is the easiest thing you can do, just like that. And if you don't know anybody in your local region, reach out to myself or Deja or Victoria, even, especially Victoria. For those who don't know, our missing panelist is a member of Trans Latinas, which is a national org of Latina trans people who are Latino and Latina, and are pretty impressive in terms of outreach. And if we don't know somebody, we can find somebody who does, and we can help you out. There's no question there.
Thank you. Yeah, and I will see if Victoria, who, unfortunately, again, is under the weather today, but was hoping to join us, I'll see if she has anything she wants to share with the Learning Collaborative community as well, and we'll be sure to send anything along from her afterwards if she does have anything to share. So now I'm going to move into our just open Q&A. We have gotten a lot of amazing questions. For folks on the line, feel free to continue putting questions in the Q&A box as you have them. We'll get through as many as we can. And then if there are any left over, I'm going to ask our amazing panelists to maybe help me respond to those after the session, if that's okay with you too. Okay, so the first question here is, I manage some amazing trans women of color that have been doing the work for years like me. What words of advice or additional support can I give them to keep boundaries and not become tokenized while doing the work?
Oh, that is a great question. I say in order to not feel tokenized, you got to get paid what you're worth. So like the moment it starts to feel overwhelming or like too much, that your pay is you're not getting paid enough money, then, I think speaking up definitely helps. And I feel like trans women who are in this work, who have cisgender supervisors, I kind of feel like they're afraid of us a little bit. Like they don't want to mess up. They will do anything to make you happy. So push back a little. I think that's totally fine. And if, ask for more money, take care of yourself, days off, utilize that sick time, mental days off. Like you got to take care of you. And, I think people forget that this work, as a trans woman, helping other trans women, whether they're, transitioning, when you're transitioning, and, it's a lot, it's heavy, and you got to be able to advocate for yourself and say, I need a break or I need more money.
I'm going to say that having been a token for like 15 of the last 20 years, my thing is make sure that they have more responsibilities than just trans people. Most organizations hire trans people to do trans people, which is what we want. But keep in mind that once they're there, you're going to find out that they can do more than trans people. My actual job title may be Director of Trans Services, but my job description is underserved populations across the board. So that means I'm also dealing with the entire LGBTQ population. It means I'm dealing with veterans. It means I'm dealing with Native health. It means I'm dealing with every population that we forget exists. I am grateful that within the Latinx community, I don't really have to worry about that in Borrego because we have a really high population of our employee base. But at the same time, we have 1,200 trans patients at Borrego Health. And I have 4 navigators and myself. And then we have another trans person in another department. And we have 2 parents of trans youth in 2 different departments and everything else. And that's important because you're going to stop feeling as if you are some form of token when there are other trans people there doing work that is not exactly about trans people, or when you see that there are more trans people around you than that. And so I'm going to look at that point, which is don't just hire trans people to do trans things. Trans people are pretty amazing. We created satellite radio, for those of you who don't know. We pioneered the use of X-ray to identify tuberculosis back in the early 1900s. We created instruction sets, which allow all of us right now to be able to communicate, because those are how computer processing units, the little CPUs that Intel and AMD make all the time, those things function on instruction sets. If they didn't exist, we wouldn't be able to have our little meetings right now unless we were doing them on gigantic room-sized machines. Those things didn't exist before us. And we created them as trans people. So it's important to keep in mind that, we can do an awful lot. If you need programming done, you can find an awful lot of trans people who are extraordinarily pale doing that kind of work. But the rest of us pretty much cover all the other grounds. I know Deja's like, oh my God, Tony, you're telling all the dirty secrets.
Girl, you're spilling the tea. I can't do nothing. That's all Tony.
I couldn't program my way out of a wet paper bag, or a dry one for that matter.
Girl.
I hope that answered the question.
Thank you. Thank you. Yes. Well, we have some great action in the chat, just appreciating both of your responses to that question. So thank you. Thank you. Deja, this is a question for you. How does the anonymous testing work at the San Diego LGBT Center? So let's say someone comes back preliminarily positive, but they just rush out of the center or are not willing to talk. What are the steps taken after that?
Yeah, that's a great question. So we do, like I mentioned before, we offer anonymous and confidential testing. And so it's up to the client whether they want to, decide what they want to do. And so when a client does decide anonymous, in that conversation, before we sign consent forms, I'm going over consent forms. And in those consent forms, it says, like, if the test were to come back preliminary positive, there's a second test that we do, which is the confirmatory test. And the test then begins to go to a confidential test. So the client already knows the steps, what happens if the test were to come back a preliminary positive. The there hasn't been any issues where the client will immediately just like rush out, or like a lot of the times they're like sitting with us, they're talking with us, they don't know what's happening, this is all new, so it's a conversation, but the client does know ahead of time what the steps are if the test were to come back preliminary positive, whether it's anonymous or confidential. We go over all of that. Great question.
Great. And Dr. Dorsey, this question came in for you. In regards to the body part inventory, what's the line between asking these questions to be informed about our patient and treat them as needed versus sounding like we're dehumanizing by using words like inventory? What's acceptable and perhaps not acceptable, or taking things too far?
That line is going to depend on to what degree you're going to use that information. If you are, for example, working at an FQHC, such as myself, where you have providers who need to have that information in order to be able to make effective medical decisions, they're going to need more information than, for example, your tester at a community event. So that's your line. It's what is it that you actually need to know for the purpose of doing it. These are not questions you're going to ask on a form, that you hand out to the patient and do it where they are sitting in a room filled with other people when we're not in the middle of COVID and filling out. No, these are questions that you're going to do an interview with. In the case of my own people, my navigators do that in that interview at a scheduled time that's convenient for the patient, blah, 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 blah. And they're trans people, so they had to answer those questions as well as ask them, and they're a little more sensitive to it. Now, does that mean that you're saying, hey, you know what, I just want to collect all your things? No, you're doing it for a purpose, and it's the purpose that determines that line. And that line is always going to be based on what is the value to this patient. The reason why I may want to know if you have a uterus or not is because that allows me to say, hey, am I going to have to do a cervical exam with you? Am I going to have to schedule you for a hysterectomy as a transmasculine individual ahead of time so that I know whether you need to do that? If you've already had one, I don't need to schedule it for you. If you have PCOS, that's something else that I'm going to be able to use, and that might actually make it a little easier for me as a provider and or administrator to make sure that you can get that particular surgery that's going on. If you're a trans woman, you know what, I want to make sure that you have a PSA test so that you get a mammogram, because hey, guess what? I don't want you to have cancer. I want to take care of your health. I want to make sure that from the moment you started your transition to the moment you end on this world, you are in good health so that you can have the best experience in your life and as possible, even though the rest of the world tends to pile on us.
I was also going to add, I can't tell you how many pregnancy tests I've been asked or taken or and I'm just like, you don't need to do it, but are you sure? Are you on birth control? And then it's the whole thing, right? So, you got to just be cautious.
When I will be blunt, whenever I get offered a pregnancy test, I take it. And they're like, wow, that's the weirdest pregnancy test result ever. I'm like, hey, you wanted to know. You didn't ask me if I needed one. You didn't ask me if there was even the slightest chance I could be pregnant. I did it. And I'm just going to tell you that the reason why is because, hey, I want to be pregnant. Well, I did. Now I'm too old to want to do it. But I mean, that was a big deal. I'm sorry. At this point, having raised 5 kids already, I'm like, no, I'm done with that thing.
Yes. Yes.
I'm sorry. And yes, it is a requirement that we see very often. But the thing is when you actually read the rules, there's no actual requirement that you do it. All of it is, well, we just want to be safe. And so it becomes fixed in people's minds. And I'm just going to tell you that that's one of those really subtle biases that we look at all the time. That from my perspective, as somebody who works in systems and develops that stuff and policies, I'm like, you know what, stop that. And it's amazing how hard it can be to do it. And then all of a sudden I get well, you're trying to make life harder for women. I'm like, no, I didn't say anything about, cisgender women. I said, why are you making life harder for transgender women? Big difference.
Or just I think of our lesbian community or folks who don't engage in penetration sex with a penis. They don't need to take a pregnancy test either. So it's asking the appropriate questions. Yeah.
Well,
yeah, I would say asking your inventory and how do you use it? I mean, I wouldn't ask that, but in my mind, I would ask another trans person that. I think that's okay. I'm gonna ask my trans friends.
Thank you. So another question we have, I think this might apply to both of you. In developing a holistic program to support trans folks, what non-HIV, non-STI resources would you recommend kind of as key resources that you would want to either have on site or make sure that you're connecting folks to who might be able to use them?
Yeah, at the center we have several services and departments, and our project Trans is one of those, and that has support groups, name changes, helps with navigating the healthcare system along with myself. It's very specific to the trans person outside of HIV services, and I think a lot of times when trans women, you either are looked at as a sex worker, or you have HIV, or you're here for an HIV test. And there are additional services that we need, and so having those available, housing, food insecurities, a place to go and hang out, upcoming shows, creativity, groups, support groups, anything that, any kind of club like that is specific for trans people or for trans people. And if it's not available, let's create it, So, yeah, I've just gotten back into gaming and like playing with the PlayStation. So I'm like, I need to get a group of trans girls together so we could like play Mario Kart or something, So, create it, have fun.
Horizon Zero Dawn sequel, Horizon Forbidden West, comes out the middle of February. I might not be contactable that last week.
You'll be busy. Booked and busy.
Hey, that's a great answer. I don't really have a bit on it, which is rare for me, so enjoy it.
Thank you. Another question we got is, are you worried about an undercount of trans people if once birth certificates are corrected, gender at birth and current gender do not highlight the transition?
Oh.
I think that's up to the trans individual, to be completely honest. I love being trans. I will tell you I'm trans, but also like my birth certificate says I was female, and so for safety reasons, I don't need to go into the airport and announce, a transgender woman is here. I just need to walk among society, go to the bar, show them my ID, order me a drink, like, no big deal. I could walk and be normal, but also I love that I'm finally able to do that. Like, I've worked so hard to really be the woman that I am. So why, so I think it's all individual based for that.
Thank you so much. And Dr. Dorsey, I know you talked, oh, great. Okay.
Yes. Okay.
So I'm just going to tell you that when you ask me to sign on a form, if that form does not have an option for me to mark that I am a trans woman, and I don't mean MTF, I don't mean AMAB, because I don't actually subscribe to that as a scientist. If it doesn't say trans woman or transgender woman, I'm going to skip it. My own system that I work with every day does not have me listed as a transgender woman, or sorry, as a male to female, because I don't, that's an insult that recenters the masculinization that I suffered through as a child. So it re-traumatizes me as an individual, blah, 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 blah. But so I am listed in my own system as a woman, female. That's it. That's what it is. Now, my system has an additional thing that we created into it that allows us to say, these are our trans patients, but there's nothing otherwise that identifies that. There's no, it's not based in a diagnostic criteria. It's not based in a demographic structure. It's strictly, these are trans patients. And the reason we do it that way is that these are trans patients doesn't show up in their chart, doesn't show up in other things. And that's important because when you're dealing with insurance and medicine, a trans person can actually have some problems. I've had PSA tests returned to me for charge so that I had to pay the $450 for a PSA test because I'm a woman, and it was not necessary. And that's important to keep in mind, is now I'm having to out myself to my insurance provider, which I should not need to do. There's no reason for that to happen. There are actual cisgender women who have a prostate that need to be examined. And I don't mean intersex or something else. I mean cisgender women that have a prostate they probably don't even know about, even though typically they wouldn't have one. But those are key elements that we need to see included, and it allows them to not have that floating over them with the high levels of stigmatization that we see in the trans community, which is even greater than HIV at this point, in their records for the rest of their lives.
So speaking of insurance, we got a question, are insurance companies required to cover trans care? And if so, to what extent? Hormone therapy, surgical interventions, mental health support, etc. So this question is for either or both of you, if you'd like to chime in.
It's all yes, 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 yes. The short answer is yes. It gets complicated because there are a lot of barriers, a lot of gatekeepers in the healthcare system, in the medical system, and insurance, and it feels like we have to prove who we are before any type of intervention can happen. So, for example, seeing a therapist for 6 months to a year talking about gender before starting hormones, and then being on hormones for a year before having surgery. So it's a long process. Yeah. So yes, they cover it. Yes, they should do all of those things, and it should be done quicker. There shouldn't be so much gatekeeping, but there is.
So when I introduced myself, I mentioned the World Professional Association for Transgender Health and the standards of care. I'm just going to point out a couple of really simple things. The state of California says that it's all supposed to be covered. Doesn't give any specifics, doesn't identify anything specifically, doesn't do anything else. So different insurance companies provide, or different, both managed care plans, Medi-Cal, and everything else. All of them have different rules. And they all have different policies for what they include and what they feel is necessary to include. For example,
there's a fine line between a reconstruction and cosmetic. And it's a very fine line. It's a very fine line.
That line is determined typically by one or two people in each individual insurance company who may or may not have ever dealt with their own personal internalized biases towards transgender individuals. So it can be a really big challenge. I'm just going to say, as an example, Inland Empire Health Plan actually covers hair removal on the face for some trans patients. No other plan in our region for the San Bernardino and Riverside covers that particular thing, except in the case of surgical areas where they're going to have surgery down below. If they're covering that surgery down below, which they do, but usually you have to fight them. It's an ongoing thing. I'm going to tell you a really simple rule to remember. Insurance companies do not have to follow and comply with the standards of care that providers do. It sounds really strange to say that, but that's the way that it actually ends up working. And as a direct result, it means that the particular insurance plan that a trans person has is what's going to determine their effectiveness. Some employer plans will have coverage for this, but they won't have coverage for that, and they're outside of it. A self-insured company does not actually have to follow any of the laws, state or federal, relating to it, because self-insured plans are exempted from those rules. Now, that's the law. The question is it right? And if you have an insurance company that is giving you problems and you have a contact for that insurance company, please do not hesitate to reach out to me. I'm going to have some fun. That's what I spend about a third of my time doing right now, more than anything else. And especially with the Standards of Care 8 coming out, one of the things that I have to do is I have to go through all of the partner insurance companies that we accept, and I have to start talking to all of them, because some of them have plans and coverage bases that are based in standards of care that are from the 90s. We're talking standard of care version 4, standard of care version 5, and those are still in their requirements. We're now in standards of care version 8, so they're going to be significantly outdated and they need to be updated. And it's very difficult to get to the plan writers, the underwriters that do the actual description of all of that for anybody in the system if you're outside of the insurance proper. So there you go. Yeah. Short answer, yes. Long answer, oh, have so much fun. And it really isn't fun. There's so much snark when we say that.
Well, thank you so much. I really wish we had another hour and a half or more, but we are out of time. So I just wanted to thank our incredible panelists again for sharing your work, your experiences, your open and honest thoughts and insights and wisdom with us today. And I also want to thank all of our attendees for your fantastic participation and great questions. As usual, please do look out for a follow-up email from me with relevant information from the session and also a link to our evaluation form. And we will post the recording and slides by early next week on our EHE Regional Response webpage. And I'll be sure to include a link to that page in the follow-up email as well. So thank you all again so much and have a great day.